Hello and welcome to this edition of the IFS Zooms In. I'm Paul Johnson, Director of the IFS, and this week I'm delighted that we're talking about a rather big issue of what's happening in the NHS, both what's happening pre-pandemic and especially what the challenges are now as we hopefully begin to come out of the pandemic. Joining me today are my colleague George Stoy, Associate Director at the IFS, who runs our work on research in health. But I'm particularly delighted to welcome Saffron Cordery, who is Deputy Chief Executive of NHS Providers, which is the umbrella body for all NHS trusts across the country, the groups who run hospitals, ambulance service, mental health services, and so on. And so very much in touch with people who are right at the front line of health delivery. We're going to set a little bit of context before we jump into the state of the health service today, perhaps just by reminding ourselves where the NHS was 15 months ago before the pandemic hit. And George, perhaps you could start just by providing a little bit of numerical context. What had been happening to health spending over the previous decade, and what had that meant for spending on health?
The NHS had been facing growing pressure just prior to the pandemic. Over the course of the history of the NHS, spending increased after taking account of inflation by about 4% per year on average. But that was very lumpy. So some periods it went up by a lot, some periods it had gone up by not so much. So in the 2000s, we saw spending going up by 5 or 6% per year. That was followed from 2010 by a decade of actually very small increases. So they were still going up year on year, but by more like 1 or 1.5% per year. That had started to accelerate a little bit more in the last few years prior to the pandemic, but still below sort of the 4% figure that most experts think the NHS requires to meet most of the pressures that it faces.
And what did that look like in hospitals, Saffron? I mean, to what extent were they at capacity or struggling to meet demand pre-pandemic?
Well, it's really interesting, isn't it, to think it almost feels like there isn't a world pre-pandemic. But if we do cast our minds back, we were in a place where the NHS was struggling financially. So it felt like funding was incredibly constrained, despite the increases that we saw. And I'll perhaps come back to that in a moment. But what we did see was demand rising and rising year on year. And this wasn't just demand for A&E services. This was demand across the piece. So this was about elective care, routine operations, and it was also demand for wider services, including mental health services. So we saw demand go up. We also saw huge challenges in terms of the workforce. So if you look back pre-pandemic, the vacancy rate was around 100,000 staff across the NHS in England. That's somewhere about 9%, which is quite a high vacancy rate. So we had this double whammy, demand going up and a workforce which wasn't there in enough numbers to really be as effective as it could be. And I think there's one exacerbating point I would put in there is if we also think back pre-pandemic, we were grappling with Brexit and what that would mean in terms of the challenges, particularly for the supply of workforce. So we were in quite a tricky place pre-pandemic. And I think that we always say that if you're in a fragile place, then resilience is going to be significantly compromised if you're tested. But I don't think we expected quite to see this test.
It's quite remarkable what you describe, this growing demand for all sorts of services. We usually think of ourselves as getting richer and hopefully healthier. I mean, what's your understanding of what's driven this ever-growing demand for the services of the NHS?
I think there's a number of factors, actually. So I put three things together. I would say that we had some demographic changes. So we know, and it's the age old, it feels like such a cliche to talk about an ageing population, but an ageing population is what we have, and that does as we get older, we get less well, and we require more care. No matter who we are, no matter how healthy the population, we do require more care. And I think that that's the first thing that is absolutely critical to remember. I think the second thing that we have to remember is that there are other lifestyle factors that come into play that contribute to demand. You know, we've got a society, a population that is actually less fit in many ways. Obesity is growing. And I think also there are huge divisions between the most well and the most unwell. And that kind of ties into the whole issue around deprivation, health inequality. So those who are really unwell have a number of factors that mean that the demands they make on the health service are greater, and we have growing numbers. We had and have growing numbers of those groups within society. And the other thing I would point to is the fact that whilst we often talk about the NHS as a treatment service rather than a wellness service, and I think that's true to an extent. And I wonder also the extent to which we were or have been investing in prevention to the extent that we need to. So how much are we really getting in? Have we really been getting in early in terms of preventing ill health and preventing those factors that make demand? So there are a number of elements there that have really contributed to demand. But there's also the fact that as societies grow richer and as we understand what health services can provide, our expectations also grow. And I think that's another factor that we need to bear in mind here, which is if you cast we can't cast our minds back to the start of the NHS, but were you around at the start of the NHS 73 years ago, you would know that it was about making sure that there was health services in extremis for people free at the point of care. So it wasn't about the whole host of amazing and astonishing services that we provide now. It was about providing that basic health care. So I think those are the factors that I would put on the table. And perhaps I would also throw in, more controversially, the diminution of the broader welfare state, actually, and the extent to which we are investing in the economic well-being of individuals, and that plays into deprivation, I think.
So, and it's interesting, you go back to the founding of the NHS. It's remarkable, isn't it? If you look back at the documents of the time, Beveridge and so on, they were talking about spending on health, maybe staying still, maybe even going down over time as people got healthier, as the health service was effective. And my goodness, that's proved to be an extremely ill-judged projection about the future for all of the reasons that you describe.
It's a really interesting point, though, isn't it? Because I think that is, you're absolutely right, but I think it's also a sign of the success of the NHS that we managed it back in 1948 and onwards, managed that mindset shift to enable people to think about and rely on a healthcare service that would support them in so many ways that, I think was unthinkable pre-1948. I think there's something really interesting around, I'm not a psychologist, so I don't understand that psychology, but I think that something interesting about the NHS almost being a victim of its own success in terms of the reliance of society on it, which is such an important factor, but also is contributing to this rising demand.
Absolutely. And of course, it's not unique in that sense across the world. So George, we came into this this pandemic with, as you described, spending going up really quite slowly for quite a long period of time. And as Saffron has said, that with the level of demand rising, that left the system not terribly resilient. We've now had 15 months or so of the pressures from the pandemic, and you've been looking at the extent to which this is creating backlogs and waiting lists. I mean, just give us a sense of the scale of the challenge from your point of view that we face over the next few years.
It's really substantial. So with colleagues at Imperial College London, we looked at what didn't happen in the NHS compared to previous years. So if you look at hospital data, we looked at the period between March and December in 2020 and compared that to the same period in 2019. And you see that there was there were a lot of elective or planned procedures that didn't happen. So those fell by about a third. In other words, there were about 3 million fewer planned admissions to hospitals during that period of time than the year before. Outpatient appointments is pretty similar as well. So we saw 17 million fewer outpatient appointments over that period. That is really very substantial, and those are things that in the main will have to be made up over the coming few years. It's not something that's going to be solved instantly, but most people are going to still need that care done. They might actually need more care done if they've become more sick. It's become more complex. They're in more need. And of course, there'll be the people who usually would have been progressing onto these waiting lists and needing those surgeries going forward over time. So a lot of what the NHS usually does has been really disrupted. On top of that, we actually saw very large decreases in use of emergency care as well. So whilst it might be reasonable and kind of expected to think that the planned stuff was going to be reduced because of the way the NHS was reorganising itself to quite rightly, in my opinion, focus on the impacts of the virus. There's also been kind of a big demand response from patients as well. So over that period of time, we saw just over 1 million fewer emergency admissions to hospital as well. That is partly explained probably by a genuine decrease in the need for such care. So if people were staying at home more, there are fewer diseases outside of COVID being spread between people. Maybe people didn't need care so much. But there is a why that there was a genuine need for some people may really have needed care during that period of time, and they're just scared to come to hospitals, and they haven't done so. And that's going to be storing up problems for the future as well. So all in all, the NHS is facing quite a challenge in meeting all of that extra demand that they haven't been able to deal with over the last 15 months or so, and that's going to be very difficult to manage over the next coming years, really.
And what can we see at the moment in waiting list figures?
They've really gone up. So the last set of waiting list figures in May said there were about 5 million people now waiting for planned procedure or to see the doctors before those. And actually, the thing that really is striking is the numbers of people who've been waiting a long time. So at the beginning of the pandemic, there were fewer than 2,000 people who'd been waiting for more than a year for elective care. Waiting list has actually come down slightly just prior to the pandemic because it had been a focus immediately before. But now we've seen this huge increase. So there's now about 450,000 people who've been waiting more than a year for these surgeries. And that figure is only likely to grow over the coming months.
That's amazing. From 2,000 to 450,000 waiting more than a year.
Absolutely huge increase, yes.
That is colossal. So, Saffron, what does that look like from inside the NHS? I mean, this must be pretty scary if you're sitting there running an NHS trust. You're hoping we're going to get over the hump of the pandemic. And then, as George was saying, these vast number of procedures and operations and other necessary healthcare, which is just backing up into a huge backlog.
Absolutely. And it's something that we see playing out day on day when we talk to hospital trust leaders, telling us how challenging it is. One that sticks in my mind is a hospital trust leader who said, it was a chief executive who basically said, for every one person we clear off our list, another two are coming in. So it's just, it could be incredibly demoralising. I think that the NHS is incredibly good at turning its hand to a crisis and an emergency, and this is what is now facing it, which is how it gets through this enormous backlog of care. And I think what we've seen over the last 15 months has been astonishing. So we've seen the response to the pandemic where the NHS was turning its hand to delivering the kind of care that it never expected to deliver, but also creating 30,000 new hospital beds and the whole host of different types of care in terms of, critical care responses, ventilating responses. So a whole host of different ways of delivering care and redeploying staff. And now it's come back into a recovery mode, which is how does it get through all of the stuff that has backed up? And I think it's really interesting what we're seeing. So yes, there is the need to get through the people who need the routine operations. We also need to get through the people who need the diagnostic tests, and that's absolutely critical and is quite a logistical challenge. A lot of the diagnostic care is particularly susceptible to being slowed down by the infection prevention and control, social distancing, which is probably taking out about between probably 20 and 30% of capacity at the moment, which is why it's really hard to get through the backlog. I think the other thing that we have to remember, and this is for me a really, really important point, which is that these backlogs don't only exist in acute services. And I think if we could take a moment just to reflect on what's happening in mental health services during the pandemic, which have not been much talked about because they aren't about physical healthcare. They've flown under the radar in a sense. But we recently surveyed our mental health trust leaders, and all of those that we surveyed, 100% said that their demand had jumped over the last 6 months, and over 80% said that they were really worried about how they were going to manage the next 12 to 18 months in terms of particularly around children and young people's care. And they're talking about seeing increases in, say, eating disorders of something like between 30 and 50% in terms of demand. So, really hugely challenging figures there. So it's not just about acute care. This is going across the piece. And I think that we have to remember that the NHS works as a whole system. It doesn't just work as the hospitals and then everything else working as satellites around it. Obviously, we all focus on hospitals, but the relationship with other bits of care is hugely important. So growing demand in mental health services puts real pressure on A&E services, for example, where, A&E departments will see huge numbers of mental health patients through the door. If demand is rising in mental health, it's much harder, of course, to get a consultation, to get people admitted, et cetera, et cetera. So it has that knock-on effect. And I wonder also here if we might talk about, I don't know if this is the right time to talk about social care, because it feels a little bit like it's the dog that hasn't barked in this whole conversation in terms of the impact of really fragile social care services and what that means for the whole of the health and the care system, where, flow of patients was an issue pre-pandemic, supply of social care capacity during the pandemic and afterwards is also a huge challenge. And, I think whilst we would, we know that our colleagues in social care have really suffered during the pandemic, we also know that it's the key to recovery. So there's some challenging bits coming into the pot there, I think.
So some really challenging stuff here. So we've got a combination of the acute services, the waiting lists for elective services, mental health services, as you say. That's shocking. Every single mental health trust saying they've had a big increase in demand. I mean, that is a shocking statistic. And as you say, social care. I mean, let's talk about a couple of those. We'll come back to social care, but I mean, to what extent are we inevitably now going to get an increase in death rates from cancer and heart disease and so on? To what extent do you think the health service is going to be able to keep a lid on that?
That's a really interesting question. I think it's going to be a long time before the figures show us what the impact of this will be. One of the things that I was struck by when George was talking was about A&E demand, and obviously that demand went down during COVID. And I think it's really interesting to pick that apart a bit, because it's absolutely right that some of it was people not doing the kind of things that require them to rock up at their A&E department. So, far fewer people going paragliding or doing things like that, which, might typically, extreme sports went out the window. So that helped. I think that some people were more circumspect, probably because they were worried about accessing services, but also then realised that what they would have traditionally gone to an A&E department for, they didn't really need to. So it was a bit of a behavioural change piece. And we really hope that continues. That's my public sector broadcast moment out the way. But if people could think really carefully before they turn up at A&E, because they're still really busy, but people thinking, can I go to the pharmacist? Can I actually manage this myself rather than needing professional care? Is it a 111 call rather than going to 999? That's really great behavioural change that we need to see locked in. The bit I really worry about is the people who didn't turn up who were in desperate need of care. So the heart attacks and the strokes. I think any A&E clinician will tell you that they were worried by the fact that they saw a dramatic drop in the number of people who were blue lighted to A&E departments or who turned up who were suffering heart attacks or strokes. That's really worrying because they're catastrophic healthcare events that don't have a slow burn and they need treating. So I think that is an interesting factor.
And you saw that directly in the statistics, didn't you, George? I mean, you part of your work actually just showed this astonishing reduction in the number of people apparently having heart attacks.
Well, if you break down the data, it suggests that. I mean, not our work, but other people have shown that, for example, there was a big fall in the number of people going to A&E with suspected heart attacks, but there were a big increase with ambulance calls for a bit later on for people with, full-blown acute myocardial infarction. So it's, and that those consequences are already happened. So they're not things that are going to, be going forward. There's also those things that you were talking about going forward. If people haven't had cancer diagnosis, they get cancer, it's caught at a later stage, that's going to cause problems. And I think that is we've been thinking about how we could try and identify these in the data. And I think actually doing that in a very rigorous way is going to be really hard. One thing I would add to the kind of the worries about the drops in emergency admissions is that they've also not been very equal across groups. So when you look at the decreases in planned services, actually across kind of deprivation or across ethnicity, it's been relatively equal, and some groups have been maybe more protected than others. When you look at emergency admissions, you've seen really very large decreases amongst the most deprived patients. So people living in the most deprived fifth of areas were much less likely to go to be admitted for emergency than people in the least deprived fifth. And then when you look at ethnicity, there's a huge gradient there. So white patients saw a much smaller reduction in emergency admissions than black and particular Asian patients. Now, those are the groups that we know have been hit hardest by the virus directly as well. They're people who they're more likely to have got the virus and conditional on having that, more likely to be severely ill. So if they're also not getting treatment for other conditions as well, that's going to have really, really severe consequences going forward and drive health inequalities.
And Saffron, can I return to something that you were talking about earlier, which is the workforce in particular? I mean, presumably, it must be the case that, you said we started off with a large number of vacancies and trouble recruiting and retaining, particularly nurses and other health professionals. And we've just had a pretty awful year and a very stressful year, and a year in which, of course, a lot of them have been falling sick themselves. Yeah. And this huge pressure on demand going forward. I mean, what is your view of the capacity, the workforce capacity, to cope with these demands going forward?
So it's a really interesting picture, actually, because I think it's much less homogenous than it was, I would say. So I'd say pre-pandemic, we were talking about the main issue was supply, essentially, and we were a little worried by burnout. But I think that now, when we contrast that kind of burnout with the burnout that we're talking about now, that pales into some insignificance. So, I think, we were worried about burnout then, but I think what we've got at the moment is pockets of different factors at play. So the workforce is incredibly tired, and it's another cliche that I feel, I almost don't want to say it because that's all that anyone is saying, but it's actually true. Cliches come from a place of truth, don't they? And the workforce is exhausted. Wherever in the NHS you've been working, it has been an incredibly difficult year, and we know that a number of staff are really thinking, what is my future in the NHS now after this? Once we are fully through this pandemic, and we've got the stirrings of a potential third or fourth wave, depending on where you live in the country, coming. So it's, I think people will hold on for a little while longer. But our fear is that there will be a group that do decide to call it a day. We then have another group who are those who have been inspired to join the NHS because of the pandemic. And we know that there's been a little bit of a bounce in terms of those signing up for training places across the board. And that's really positive, particularly for nursing training. So that's really important. But of course, that won't actually make any difference for another 3 or 4 years. So we have to remember that that's a medium-term solution to our problem. And we have to make sure that there's no attrition rate in terms of those staff who sign up and then perhaps fall away further down the line. So, but we do have a kind of new influx of staff. I think the other bit that we've got, and this has been one of the really interesting bits of the pandemic, is how we kind of loosened up a little in terms of attitudes and approaches to workforce. Everything was less rigid. We required more flexibility, more innovation, and I think we've seen a lot of opportunities for people to take on different roles, work more flexibly, think differently about their careers. So I think we may see a lot of switching in the future as well, which may not add to the quantum workforce, but might mean that people have a wider set of skills to bring to the fore, which will be incredibly helpful. And I think one of the elements where we really need to see that is where we need to see the workforce working across primary and secondary care and out into the community, because we know that there are huge challenges out there in primary care as well. We haven't talked about that particularly, but we know that has an impact on hospital services and on the wide range of secondary care services. So it's a mixed picture in terms of workforce, but it's a challenging one. And the thing we haven't got to the bottom of is how we give staff the rest that they really need before they then gear up for what is going to be a couple of years of incredibly hard slog to deal with demand and get through the backlog.
Because George, again, looking at the data, that was already worrying on workforce 15 months ago, wasn't it?
The government has already commitments to increase workforce size. There's a well-publicised target of trying to increase the nursing workforce by 50,000 nurses over this parliament. For all the reasons Saffron said, that might be a lot harder to meet, if you think, just after this pandemic. So yes, those challenges aren't new, and I guess there's something that there's never been a great deal of coherent planning, as far as I'm aware, about how you really expand that and you keep staff and reward them. One element, I know we were talking about kind of rest, the other element is pay here. We are coming off a decade of essentially a pay freeze, or actually a real terms pay cut for many of his staff. Subsequently, there's suggested they're going to get a relatively small pay increase after all of this. That might also frustrate people and lead to kind of worse retention. So we've done some work previously which actually does show that pay matters for retention of nurses, particularly in the hospital sector, where there's way that pay is regulated in the NHS is it's relatively fixed across the country, but people's cost of living is going to be very different. So if you look at house prices, they vary massively across the country. And so people's sort of real pay or relative pay changes quite a lot. And you see that in areas that see very big increases in house prices or cost of living, you see nurses leaving at quicker rates. So that suggests that, pay is going to matter a little bit. A bit more flexibility is also something that's important.
Yeah, it's quite something, isn't it, that, as you say, the real wages for many professions in the NHS are lower now than they were a decade ago, which is obviously not going to help with retention. I suppose the question is, what do we do about all of this? I mean, to what extent is this all about money, and to what extent is it about other actions that government or NHS should be taking?
I think there's a really interesting bit here for me about, George touched on health inequalities, but I think that this is an area where I think that it's been a time of reckoning really for the NHS. Well, it's been a time of reckoning for society on health inequalities, but I think it's also been a time of reckoning for the NHS in terms of looking at the problem of health inequalities from a number of different angles and different dimensions. And I think it's one bit that it has been the challenge of the pandemic, but it's also the opportunity to get to grips with it once and for all. And I do think that is really important. One of the things that we have seen starting to happen is things like looking at the waiting list, and rather than cutting the waiting list by clinical priority, so P1, P2, as it's traditionally looked at, it's also to cut it alongside that by health inequality factors like deprivation or ethnicity, in order to get a much more rounded picture of what needs to happen in terms of really tackling waiting lists and getting them down. But it also speaks to the need not only to change clinical practice around health inequalities, but also attitudinally to change and help understand what is happening to, certainly what has happened to staff on the front line during the pandemic, in terms of, some staff potentially not wanting to undergo the risk assessments that were put in place for every single member of the Black and minority ethnic workforce, so that they weren't put at increasing risk, but they were very, very clear that they didn't want to see their access to really important frontline roles for them taken away, and what that might mean for their career. So there's been some really interesting grappling with a number of issues here around health inequalities, risk, exposing different groups to different levels of risk, and also trying to tackle that head on and really take the lid off the levels of discrimination that are built in to the healthcare system, in fact, into all of our systems in society, but particularly into the healthcare system. So I do just want to focus on, I just wanted us to focus on that for a moment, because although it's been we could characterize it as a huge challenge, it is also the flip side of that is the opportunity for the NHS to get to grips with this.
Really hard health inequalities, though, isn't it? I mean, and in the end, how much of health inequality is down to the NHS, and how much of it is down to the much broader inequalities in society? I think it's probably much more to do with the latter. And I suppose the question is, how can the health system, the health service, engage and help? But you also need government, local authorities, and the other parts of the welfare state, and indeed, the labour market and everything else working together to help out on that one.
I think that's true, but if you remember that there's 1.1 million staff employed in the NHS, it's the country's biggest employer. It probably acts as a microcosm of society in a way that no other field of employment does. So I think that there's this definite sense of responsibility amongst trust leaders that we talk to feel that this is their opportunity to get this right now, and that it plays out in a way that perhaps doesn't in other fields.
So clearly absolutely one big priority for the future is dealing with health inequalities. I mean, George, what's your view about other things beyond pouring more money in that needs to happen to help the health service deal with the clearly very, very big challenges coming down the road?
Very difficult to say. I mean, with workforce, I think as long as with the funding, I think trust could do with flexibility to use that money in a way that allows them to reward staff or to plug holes that they need to. So to incentivize people in certain specialties or things like that where they're failing to keep people. One problem with kind of training new staff recently has been funding of training places. For example, the bursaries for nursing weren't there. So things like kind of making sure that there is funding for all of that going forward, I think, is important. In terms of the meeting the demand, I think that is, yes, it's going to be really difficult. It sounds like, hospitals are really going to have to work very hard at this. They're going to have to run clinics at all kinds of times of the night and the weekend to try and catch up with things. And that is hard to do, as Saffron was saying, on the back of people being exhausted already. It raises questions about where can you get capacity from otherwise. Can you bring in staff from somewhere else? Can you bring in equipment from somewhere else? Should you be engaging more with the private sector, for example, which raises thorny issues in itself. But that's a conversation that's kind of worth having, perhaps.
And anything further from you on this kind of huge question, Saffron? I don't know how. If you were in front of, if you're talking about, I'm sure you do talk about Hancock. I mean, what's your ask of him beyond money?
So I think that the money is important, always important, but it's also, I think George was right, it's how people are allowed to spend that money as well and what they can get their hands on for the money. So I think for me, we've got a comprehensive spending review coming up later this year. So we will certainly be making a number of big asks in that. And one of them is a workforce plan, a proper funded workforce plan for the next 3 years and beyond, because without that, the NHS really can't plan effectively. We need to know what's there in the pipeline and understand it and be able to work with that. And that isn't really as clear as it might be at the moment. And I think it's been one of the big oversights of policy in recent years. I mean, everyone says that it's impossible to fully plan the workforce. Of course it is, but you can make a pretty good stab, and a pretty good stab means that you get to a better place than if you don't have one at all. So that would be one thing I would say. Something we haven't.
Many listeners may be shocked that such a thing doesn't already exist.
Yeah, I know. There we are. I'm going to move swiftly on. The second bit, and we haven't really talked about this, but I think a lot of the solutions lie in some of the really fundamental nitty-gritty issues like capital investment. And I don't just mean bricks and mortar, though that's really, really important. So we need a healthcare estate that's fit for purpose. So we need mental health patients not being treated in dormitory wards or untherapeutic environments or in places with features that are incredibly dangerous to them. We don't need leaking roofs or air conditioning problems in operating theatres that reduce capacity even further. And we actually need the improvement of the overall NHS estate so that we bring it into the 21st century. So, we've got a new hospitals programme, but that needs to go further and faster, frankly. And that's exacerbated massively by COVID and the need to be able to have hot and cold sites so that we can treat people in COVID-free environments much more easily without slowing down progress with the very extensive infection prevention and control. So if you've got a COVID-free site, then you're much freer to do what you need to do. And that's really important. Another element is digital transformation, which we also haven't talked about that much, but that has been one of the surprising and important elements of changing mindsets in people, that they can access services digitally, and it's been made much easier, and we've gone further and faster on that. But that needs way more investment. I mean, that is a pure money issue, actually. And then I think that a couple of other elements that are critically important. One is if the spending review, I think we're pinning a lot of hopes on the spending review, but it really has to invest properly in prevention and public health. It's a bit of I wouldn't go so far as to say it's a scandal what's happened over the last few years, but public health has been underinvested in, as has the whole of local government, which brings me neatly on to social care. So a solution for social care would be absolutely fantastic. because that would help so many people in so many different ways, as well as providing the right quality of care for people who need it.
And we've been waiting for a solution for social care for an awfully long time, and we keep on being promised it. I mean, George, you've done some work on the impact of inadequate social care funding on the NHS itself.
Yes, so it looked at between 2009 and 2018, the big cuts we saw in social care funding for those who are over 65. And in that period of time, we saw per head funding for social care fall by about 30%. So we were talking about really substantial falls. But they varied quite considerably across the country, depending on how reliant those local authorities were on central government grants to begin with. But you saw that essentially the estimates show that there's very large impacts, particularly on A&E services in hospitals. So patients or people who are not getting social care anymore are turning up in the emergency departments, which were already really overburdened. And although actually most of them don't seem to be admitted, this sort of the oldest and the frailest do, that still has consequences for their health. It has consequences for the way that hospitals run, because these departments are busy already. And it's not a good way to run a system where if you could have people treated in their own homes, for much more minor things, or not even I shouldn't say treated, they're helped with things that they have, everyday activity problems, then you could avoid all of those kind of problems. One thing I would say there, though, is that we didn't find a lot of evidence that it led to lots of costs for hospitals. So whilst there were quite large reductions in costs for social care provision, it led to lots of people in emergency departments, but those people weren't necessarily admitted. So I actually find that often there's this argument that we should save money overall if we can cut funding. We shouldn't cut funding on the social care system because it costs us more in the NHS. I don't think that's the right argument. I think there's lots of good reasons why we should fund social care properly. And part of that is the interplay of the NHS, but I don't think it's just the funding.
Yeah, clearly the good provision of social care is good in itself. And very striking the number you said there, a 30% cut in funding per head for social care over the decade up to 2018. So we often talk about social care in terms of people's worries about having to sell their homes and pay for it themselves, and the structure of the funding of social care, which is, of course, absolutely vital. We perhaps don't talk about it quite often enough in terms of just the inadequate level of resource that social care has. And those are two different questions. Those are two different issues. And part of the reason, I think, why government has consistently failed to deal with it. Look, Saffron, George, we've been going for actually way past our allotted time. So fascinating and fantastic has this discussion been, and clearly a huge amount more we could talk about, which is not surprising when you think that we talk about the National Health Service, and this is something I glibly say quite often. I mean, when it is 10% of the entire economy, which is broadly speaking what health is, it's not surprising there's quite a lot to talk about and quite a lot of problems and quite a lot of issues. But we've covered an enormous amount today. The stretch that it was under 15 months ago, the problems that the workforce is facing, the huge backlogs that we're getting, this big increase in demand for mental health services, the pressure that the social care system is under. So no doubt we'll come back to this issue again and again. But I mean, that's been a really fascinating and really quite worrying run around a lot of really important issues. So thank you very much. Thank you, everyone, for listening to this edition of the IFS Zooms In. And for all our latest work, please visit www.ifs.org.uk, where you'll find a lot on health, a lot related to COVID, and a lot related to the public sector and public policy more generally. And to further support our work, do consider becoming a supporter of the IFS for just £5 a month. You can find a link with further information in the episode description. Thank you for listening, and stay well.